happy to invite Dr. Akapfili to join the panel. And as you have heard already, he has a vast experience with the NICAS in the community, in particular in patients with heart failure, and also in patients, as mentioned, following therapy for various forms of cancer. So if you would like to tell us something about that, it would be very interesting. Thank you.
Thank you. Thank you, both of you, for very impressive and comprehensive review of the topic. I think I know NICAS at least 10 years, and during my years in the intensive care unit, we used to be very, very active in using NICAS for acute hemodynamic compensation of the people, and it was very, very easy and very helpful. And when I moved to community, I asked myself if I can transfer my experience from acute cardiac care to community setting, and it was very exciting for me that my team in community care took this thing very warm. Why? Because it's very easy to use. My nurse can do it without even asking me, because you even don't need to undress the people. You can attach the electrodes to the people in the usual dressing, and you can get the hemodynamic information like your right heart cath. So it's very exciting to be able to join these very distant dots in our physical experience. So first of all, it's very important that it's a fast examination. Again, it can be very useful, and we're using it in addition to the physical examination of the patient. And when my nurse is doing up titration of the therapy, she is not doing it in blind way, as we usually do. I mean that you have only the hemodynamic parameters like blood pressure and heart rate, and that's all. In the best setting, you will have people bringing you renal function tests and electrolytes, and that's all. You're doing randomly. I'm being elevating beta blockers, adding MRA, or I'm up titrating my ACE or ARNI. So when you look at graphs and you see that the patient is vasoconstricted, actually it's quite clear what you have to do, as both speakers before me showed you. So it works very well, and at least in my place, people use it in everyday practice. Another thing is to treat and to follow the patient at their home. And it's another population who is very underserved, and they're really, really we're doing everything in the dark, because when you prescribe to make a decongestion to the people who suffer from the overload, volume overload, you even do not know about their heart function, because it's not available in every place to come to the people with pocket echo and to look at the ejection fraction. You need at least to know how much other people was constricted or volume overloaded, and usually who manages people are nurses, and nurses do not have enough experience in physical examination to diagnose very carefully and in very distinct way these patients. So I think, and I recommended it to my colleagues, and I think Igor will do this next step to implement the thing in home care, in our home care, because it's really point of care device. During the years, it became from the computer-based large equipment to very comfortable tablet-based, and I think it's very important to go to this way, to this population. And the third exciting opportunity, I think, it's in terms of health economics and to the treatment and follow-up of oncology patients. We did retrospective study that was kindly shown you by Professor Cleland, and we're doing and we're planning to do a controlled trial, prospective trial, to show that following the oncology patients who are getting the cardiotoxic treatment may benefit from using this very easy and comfortable way of following them at least every their encounter with oncology team. Before doing chemotherapy treatment or biologic treatment like Herceptin or like adriamycin, instead of sending them to echo lab every 3 months and doing let me say during breast cancer treatment, HER2 positive, these people are coming every 3 months to echo lab, and without doing ejection fraction, they are not allowed to continue the treatment. If you see that, if we will see in prospective trial that it can do as good as echo and predict the heart failure in these patients, it could be groundbreaking, even groundbreaking, because we can reduce dramatically cost of follow-up of this patient. If you look at the last cardio-oncology guidelines by ESC, it's +1 indication to follow this patient every 3 months by echo. Imagine if you can follow them and to screen heart failure by this. If NICAS is okay, you do not need any echo. And if you see that any deterioration of NICAS, do echo and do in-depth examination to see how to can manage these people. So I think this is a direction we have to go with. And we're with Igor and Professor Vered, we're planning to do this study. And I'm very excited about these opportunities. Thank you so much for inviting me and giving the possibility to explain my view of NICAS. Thank you.
Thank you, Professor. Thank you, Professor Kavashvili. We have a question from the audience. I'll read out the question, and I would love the opinion of the panel. So the question is, what is the role of primary care physician in the treatment of heart failure? Should primary care physician be more aggressive in treating their patient with quadruple therapy? So two questions for one.
John, that's for you.
Yeah. So, well, I think I've always said that I'd rather be treated by a primary care physician who was interested in heart failure than by a cardiologist who wasn't. So I don't think there's any special thing to prevent the primary care physician taking a central role here. And I think with certainly with the advent of SGLT2 inhibitors, they seem to be very easy to introduce with very low risk. I would say the same with the MRAs, the same with the beta blockers.
Excellent. So
okay, we're filled in with a pre-lecture lecture.
Pre-lecture lecture. Yes. For people joining us now, again, thank you for joining us. My name is Igor Granov. I'm the COO of NI Medical, and I'm delighted to have you all here. And I am going to introduce you to our speakers today, Professor John Cleland from Glasgow University. I don't think you need a further introduction, but Tzvi Vered, who happens to be our medical director, but also chief of cardiology for Maccabi HMO. And Professor Yakovashvili, thank you for joining us. Professor Yakovashvili is the head of cardiology in Tel Aviv district, if I can correctly, and exactly. Of Clalit HMO. I think Clalit HMO is one of the biggest HMOs in the world, not the biggest. So without further ado, Professor Cleland, the stage is yours.
Thank you very much for that, and hopefully you can my slides.
Yes, we'll see.
Yeah. Okay, great. So I'm here to talk today about the potential contribution of hemodynamics to precision medicine. And I love some of the ancient philosophers and what they said about doctors. So Voltaire said over 200 years ago that doctors are men who prescribe medicines of which they know little to cure diseases of which they know less in human beings of whom they know nothing. Now, fortunately, we have moved on a little bit over the last 200 years. Our doctors are not just men anymore, they're men and women. We know quite a lot more about the medicines that we use. We know an awful lot more about the diseases. But I just wonder to what extent we know who we're giving these medicines to. And you've just heard a short discussion there about the number of people out there in the community prescribe loop diuretics, and we really just don't know why. And they might be